Here's where we left off on this question, or I shared with you that we would pick it up right here. So just right away start off with partnering up, and one of you define a somatic reflex arc, and the other define a visceral reflex arc. All right, I'd love to hear some of your ideas. Something tells me the enthusiasm isn't necessarily about reflex arcs. Okay, who do I have any volunteers that want to share with us some ideas about a somatic reflex arc? Let's start there. A somatic reflex arc. No volunteers? If you look at the table before this slide, there's a lot of information there that you could go to. Anyone? Bueller? Anyone know the reference? Okay, it's on deaf ears. Never mind. Somatic reflex arc. Somatic reflex arc. What is it? What is the soma? What's this referring to in contrast to like a visceral or something that's autonomic? Somewhere in the body. Do you have an example that you want to share? Like moving the limbs. Okay, so somatic. This is where we ended Monday's lecture, was this list of characteristics of a somatic reflex. Okay? Would it be valuable to know this chart? Could you anticipate maybe a test question comparing and contrasting the two different types? There's a lot of A, B, C, D, A and B only, B and C only options here. You agree? You could totally take a picture of this, but I think you have this slide. I'm just trying to highlight things that you want to remember to study. Okay, what about visceral reflex arc, autonomic? Now that you know where you can look, give me some characteristics, some major identifiers, some things that are associated with an autonomic reflex arc of the viscera. Stereotyped, unconscious, automatic. An example would be the baroreceptor reflex. I love that you understand that video wasn't just to go to YouTube and pass time. Like I'm actually trying to give you real examples. There's another example that we talked about. Do you remember on Monday? The maturation reflex. Okay, so just trying to help you categorize the information. Is that pretty clear? Okay, I promised you we would start here. And then we're going to dive straight into Lecture 2. But a couple of reminders. What's significant about Sunday evening at 11:59 other than that it's Easter? I mean, Easter is really important, obviously, but there's 2 smart books or quizzes due for GRL platform. Which quizzes are due? 9 and 11. Look at that, tricky devil. Skip 10. Okay? Inevitably, I'm going to get emails on Monday. Like, I didn't know we had 2. I didn't know which ones, Dr. Keller. So those that are absent, please tell them. Okay? Let your classmates know. Don't give them the bonus assignment passcode, but tell them that there's a quiz on Sunday. Okay? 2 quizzes. 9 and 11. All right. A couple of other housekeeping things. So I've had a lot of conversations with students in office hours. So I've got, just to refresh your memory, because I'll get emails from students like, I don't actually remember when your office hours are or where they are. It is conveniently printed on your syllabus on the front page, just so you know, as well as my email. And my office number, WETA 211. But just to refresh you, on Tuesdays at 11 to noon, I'm doing Zoom office hours. On Wednesdays from 11 to noon, I'm doing in-person or Zoom office hours. In most weeks, I've expanded those to larger periods of time. Not just those 1-hour slots. So like today it was, I was in my office about 9:30 because some of my first appointments were 9:30 until noon. Okay, so we're expanding office hours as the semester goes on. I am toying with the idea of adding a Zoom office hour on a Thursday or a Friday for those of you that have questions about lecture material on Wednesday, and you don't want to wait until next Tuesday. You with me? Okay, so it's only by popular demand. I'm very sensitive to popularity, meaning I don't want to sit in an office hour and nobody show up. I mean, I could do other work, but I mean, you wouldn't want to do that either. Okay, so I will ask the question by a show of hands. If I had a Thursday or a Friday 1-hour slot, obviously it's got to be around my schedule, but if it's Zoom, I'll record it and I can post it. Okay, but this gives you the opportunity, like some of you are doing, you come Monday lecture, you show up on Tuesday Zoom office hours, you get your questions answered about Monday's lecture. Okay, watch this. You come to lecture on Wednesday, you have some questions, not everything sinks in, you rewatch the lecture. Before the weekend, you get your questions answered on a Thursday or Friday. And then by next Monday, guess what? You've actually studied 20% of the material that's going to be on this next exam by just coming to class and getting your questions answered real time. Let's contrast that with maybe this method. I'm not saying everybody's doing it this way, but let's say this might be some of you. You may or may not show up to class. You know that Keller records it. He's pretty religious about it. He's always futzing with his technology. And it's always on YouTube. I can count on him to put it on YouTube. I'm just going to watch it on YouTube. And if that's you, great. We're watching it on YouTube. But you don't come to office hours. You're watching it. You're sort of distracted. You're doing other things. None of us do one thing at the same time. So you're on YouTube. Now, I remember I needed to buy this. I'm going on Amazon. I was kind of curious about this. You're on your social media platform. You're not really watching it. You get the weekend before the exam, oh crap moment. I am really behind. I went to like 2 of the lectures. I kind of watched 2 of them, but I'm just going to rewatch all the lectures, binge watch it this weekend, and I'll be ready for the exam. But you know what? There's these study guides, this Kahoots, and this practice exam. Ooh, that's super enticing because that looks like a shortcut to get me out of this pickle. And the only thing you really focus on is the review materials that are supposed to be supporting and ancillary and help you decide if you've missed something big. But all of the exam questions are written out of the lectures, which you actually kind of attended. Maybe you didn't. You sort of watched it on YouTube, and now you're ill-prepared for the exam. Hopefully that doesn't sound super familiar, but if it does, I'm trying to break that string. So if you come to lecture on Monday, you come to lecture on Wednesday, you get an office hour on a Tuesday, a Wednesday, or a Thursday, or a Friday. You go into SI sessions with your questions. The SIs and the TAs are in the lecture. If they can't make it, they're watching the YouTube lecture, so they know what we're lecturing on. But you got to come armed with, you can't just sit there and say, hey, I don't understand, explain it to me all over again. I was kind of listening, but not really. Could you start from the beginning? You're going to be behind. Okay, so philosophically, I want you all to kind of start lean into that a little bit and use those resources of SIs and TAs in my office hours that will increase in frequency for exams 4 and 5. Here's the other good news. It's 2 weeks to exam 4. You're like, how is that good news? You are a sick man. Okay? That means there's less material. It's shorter amount of time. We only have peripheral nervous system and muscle physiology on the next lecture, or in the next exam. And then exam 5 is special senses, and that's it. Okay? And exam 5, which we call the final, will have cumulative section, but it might be 15, 20% cumulative. It's more like a true exam 5 than a cumulative final. Okay? So there's 200 more points with exams, and I'll say this, you can plan on having 2 more bonus opportunities. 1 per unit, 1 per exam. I'm seeing some smiles in the audience, which hopefully it's not gas, and you're just really happy about this news. Okay? If it is gas, excuse you. Okay, you're welcome. Any questions about, question here. All the exams are cumulative. If you pay attention, there's a couple of questions, maybe a handful of questions that are cumulative in nature. Exam 5 will probably have a little bit more. If I say, if it's 10% and there's 50 questions, that's like about 5 questions of review. Okay, so if I'm saying 10 to 20%, it's 5 to 10 questions max. Probably somewhere more like 5 to 7 of cumulative. So how much cumulative can I go? And would I focus on cumulative at this point? I'd probably focus on exam 5, unit 5 material, special senses. So more bite-sized on exam 4 and exam 5, a little bit more focused. I'm not saying it's easier. I'm saying there's less time, there's less content. And I think if you lean into the class, and you'll be surprised, those of you who are looking at your exams, most of the realization on the exam isn't, wow, I had no idea on that question. It's, oh, I totally misread that question. Oh my gosh, I can't believe, oh, I know that answer. I don't know why I didn't put that answer. Or I changed my answer. I don't know why I changed my answer. So you know the information, you're second-guessing yourself. Which actually, it's in another sick way, it makes me happy that you're learning the material. It's just you're having test anxiety or having trouble translating it to the exam. And that's what we need to work on, okay? So you'll see the lectures shift a little bit to more of exam preparation along with content. We good with that? All right. What did one, this is a little out of place, I probably should have saved for Unit 5, but what did one eye say to the other? What did one eye say to the other?
Nothing, it just winked.
Nothing, it just winked. I like that. Another one is, just between you and me, something smells. Okay. I got a couple chuckles. What do you get when you cross a vampire and a teacher? Hopefully you don't think I'm a vampire, but what do you get when you cross a vampire and a teacher? Blood tests. Ba-boom. Okay, what do you call a person who doesn't toot in public? A private tutor. Well done. Well done. One of my kids was really proud about authoring that one. Okay. Feel free to, you can use those. You can totally borrow those dad jokes. I know they're not that great, but your dad will probably laugh on Easter if you're with him. Okay, if you're going home. Okay. Lecture 2. Let's start out with a question. Think parasympathetic system. Actually, just look at me for a second. What does the parasympathetic system do? Tell me some things. Just shout it out. Rest and digest. What about blood vessels? Lower blood pressure. What's that? Slows heart rate. Okay. So when you see a question, maybe start thinking about, in your test packet, maybe write down some things that you know about it, okay? And then, so you're not freaking out, like, oh my gosh, these are going to be really difficult, A and B only, B and C only, he's totally going to try to trick me. Why don't you just read like, hey, he's asking about the parasympathetic division, what do I know about this thing? Write some things down. Now let's look at the questions, or the answers rather. A, B, C, D, or there's that tough one, all of these, I don't know. Is it all of these? I don't know. Well, if you write down some things, it'll help you empty out your information that you have on your test packet so you can kind of orient yourself. Some of you are panicking. Just read the question and write down some notes. What are your thoughts here? Who has an idea or would like to share with us their thoughts and maybe an explanation as to why? How about back here? B? I agree. Okay, all right, first off, pause. He said it can't be all of them because it's, not fight or flight, so that eliminates two. C and E are out because parasympathetic can't be all of these if C is incorrect. I love this strategy because now you're down to A, B, and D. Right? Start eliminating answers. Keep going. It's not a rest function to increase metabolism. If I'm going to go to bed, I'm not increasing my metabolism. I'm slowing it down to go to sleep. I love that. Eliminate this one. What about A and B? Right, so now you get down to two. A lot of you are like, I always narrow it down to two, Dr. Keller, and then I'm stuck. Well, now go with what you just wrote down. We learned in lecture this is about rest and digest. Okay? So I know this is right. There's no two of these, so I'm kind of uncertain about this one. Okay? I love that. That's well done. I want you to draw a picture of a presynapse neuron with a long axon that innervates or synapses onto a postsynaptic neuron with a short axon. Just draw it out, sketch it out. It doesn't have to be pretty. Nobody has to see it. I'm not asking for volunteers. It's going to become relevant here in a minute. And then picture B is the opposite, short, long. So long, short, then short, long. So generally speaking, these motifs can be categorized as either parasympathetic or sympathetic. Anybody have any ideas as to which one is an example of a sympathetic pathway that you just drew? Long, short, A, or short, long, B. Which one is sympathetic? B. Well done. Short, long. So that's kind of the architectural organization. Short, long. So I would write in here an example, a stereotypic example of what type of pathway? A sympathetic pathway. In contrast, a stereotypical example of a parasympathetic pathway, long, short. And this motif will help us as we work through today's lecture. Is it always the case? No. But generally speaking, for our classes and on the exam, you can count on it. It'll help you characterize the way things are organized.
Why is it short, long, and long, short?
I knew you were going to ask that. I didn't know it was going to be you. I don't know. I don't have a great answer.
But just to understand the context of it, is there any more you can add to that?
Well, yeah, let's hold the question until a little bit later as we build up to the lecture, where we start looking at neurotransmitters, and it may become a little bit more obvious. The question that's being posed is, why is it organized this way? Why is it long, short? Why is it short, long? And I mean, we could sit here all day long and, have a coffee and debate why things are the way they are in the body. And there's all sorts of things like, why are the vertebrae, shaped the way they're shaped? So I don't know why I came up with that one. But there are some explanations, but not always. And in this one, I don't have a great answer for you. And I kind of looked things up a little bit before lecture today to see if I could come up with a good answer, but I came up empty. Okay, if we look at the pathway of the autonomic nervous system, the neurotransmitter that we also tend to go with the most is one that cholinergic fibers secrete, and that's acetylcholine. And so in most textbooks, especially in our textbook, and in a lot of anatomy physiology textbooks at the 200 level, you're going to hear a lot about acetylcholine. And when we look at nerve physiology next week, we might get into a little bit of it today. Muscle physiology, excuse me. We might get a little bit into the muscle phys today, depending upon time. We're going to start seeing this motif again of acetylcholine as our neurotransmitter. Now, there's an enzyme called acetylcholine esterase, and that's this abbreviation of ACHE, which anything that ends in an ACE is typically an enzyme. Usually it's a protein, and it's breaking down something, and it's breaking down acetylcholine, because once acetylcholine goes into the synapse, it's going to have an activity on its receptor, and you want it to not last forever. If it lasts forever, then you actually have a tetany response, or you have a frozen muscle contraction as we relate to muscle physiology in the next few lectures. If it's nerve physiology and acetylcholine is being used, then you're going to continuously have this stimulation across the postsynaptic nerve, and you don't want that. You want to stop the signal when it's time to turn it off. And that's one of the ways that the signal stops is because of an enzyme that breaks down that neurotransmitter. We see it in the sympathetic as well as the parasympathetic system, but it tends to dominate more in the parasympathetic nervous system. And we saw that a little bit with the maturation reflex and with the baroreceptor reflex. So let's unpack a little bit more about these cholinergic receptors. These cholinergic receptors, it's a classification of receptors. These are receptors that are found on the postsynapse side. They're going to receive a neurotransmitter. We have two different types of cholinergic receptors that I want you to know about for the exam. Be familiar with nicotinic receptors as well as muscarinic receptors. Both of these are types of cholinergic receptors. Nicotinic receptors are excited by acetylcholine. So you imagine you're drawing either one, A or B, got a short, long, or a long, short. In the synapse, let's say that acetylcholine is crossing that gap, and there's a nicotinic receptor on the other side. Acetylcholine binds to the nicotinic receptor in that example. It's going to be excitatory. It's going to stimulate a signal to be propagated. You with me? So we would stimulate an EPSP, an excitatory postsynaptic potential, to use terminology from the last unit, versus inhibitory, right? And I already tested you on this. I won't get into this level of detail on review questions. If it's excitatory postsynaptic potential, what do you think sodium is going to be doing? Coming into the cell or leaving the cell? Coming into the cell, because it's stimulating a depolarization event, right? Now, that's not the level of detail that we'll need for a review question on exam 4 or 5, but I'm just trying to bridge some of the historic information we've learned so you can actually synthesize things. But I might actually say, is that excitatory or inhibitory? Acetylcholine binding to a nicotinic receptor, would it stimulate an EPSP or an IPSP? And you would say an EPSP, right? Excitatory. Do you need to know all about the ion movement? No, I already tested you on that. That's not the level of detail of a cumulative review question. But the EPSP, you should know that top level. Does that help? Like, how deep do I study the 10 to 20% review material? About that deep. Know that it's an excitatory if it's an excitatory postsynaptic potential if it's acetylcholine binding to a nicotinic receptor in the classification of a cholinergic receptor. All right, let's talk about muscarinic. Oh, by the way, fun fact. So the name of nicotinic receptors, it was termed that because experimentally in the lab, we discovered, the collective we discovered that nicotine actually binds to these receptors. And when that happens, that nicotine response can activate neural pathways, and that is an activity of the drug of nicotine. So they were named nicotinic receptors because of their affinity for nicotine. It's kind of a weird story of why they're not called an acetylcholine receptor here, but that actually is found other places in the body. Okay? Muscarinic receptors, they were also named this because there's a mushroom toxin, muscarine, that binds to this muscarinic receptor, and that was discovered in laboratory experiments as well, and so we affectionately refer to this type of receptor as a muscarinic receptor. Now, some of these, in contrast to nicotinic, can be excitatory or can be inhibitory. And the target tissue tends to be smooth muscle, cardiac, or glands. And their excitatory or inhibitory depends upon the G protein that's being utilized. So you can see in this diagram over here, the stimulatory pathway goes through one pathway that utilizes calcium release. The inhibitory pathway goes through another pathway that uses cyclic AMP. Two different mechanisms. Now, you'll notice, if you're watching carefully on the lectures, I didn't talk anything specifically about this diagram. And in this diagram, the only thing I highlighted was calcium release versus cyclic AMP release. So that would be the level of detail that I would focus on understanding muscarinic receptors. When are they excitatory? When are they inhibitory? Well, if they're excitatory or stimulatory, they utilize calcium release. If they're inhibitory, they utilize cyclic AMP. Make sense? Okay. When the parasympathetic division is stimulated, what neurotransmitter is released at the effector organ? I kind of talked about this today, right? Just from a sheer statistical probability, what answer could you go with based upon the first part of the lecture? A. Exactly right. A. Acetylcholine. We'll look more at norepinephrine, epinephrine, and dopamine, but the slide that we're talking about is this slide where I talked about in the lecture that really the autonomic nervous system dominates with acetylcholine, and it's predominant in the parasympathetic nervous system. And then I asked a question here about acetylcholine and the parasympathetic nervous system. Okay, so this is how you're going to be capturing these notes and grabbing this information as you pass through the lectures and you watch them again. So we talked about cholinergic receptors. Second classification of receptors that we need to look at are referred to as adrenergic receptors. And if you go to the textbook, you're going to see a lot more information about cholinergic and adrenergic receptors. And I'm boiling it down to really the salient points that I want you to focus on for the exam. We have a number of different classifications. We have alpha 1s, alpha 2s, and betas. And because you have different variations, A1, A2, and beta, you actually have the ability to separate out different responses physiologically, whether it's smooth muscle contraction on alpha 1, or whether it's alpha 2, you either can have an inhibition of a transmitter release, so you don't transmit the signal any further, and you have the ability to contract smooth muscle as well, just like its cousin alpha 1. Beta, on the other hand, is very different. Beta has a subclassification of beta 1 and beta 2. And with beta 1 and beta 2, you get two completely different responses. You activate the beta 1s, you get heart myocardium contraction. You activate the beta 2s, you get smooth muscle relaxation, as well as glycogenolysis, where you break down glycogen to form new glucose. Right? That's a Unit 1 review concept, glycogenolysis. I think it's important for you to know that terminology so you don't lose all that information of what is glycogenolysis, right? This is the lysis of glycogen to form new glucose, and glucose is the way you get energy, ATP. Interestingly, how many of you have asthma, know somebody with asthma? Okay, pretty big population. Familiar with these inhalers or a nebulizer machine? Okay. Let's go with the nebulizer machine. What happens post-nebulizer treatment, right? You're sitting there, you're smoking your, what looks like a bong to me, but you're doing your medication, okay? And I guess it's a bong wouldn't be illegal now, so 10 years ago it was a goofier statement. Now it's just normal. So you're having your medication, but you're actually putting medication in there as a bronchodilator. If it's a bronchodilator, it's a beta-2 agonist, the medication. Beta-2 agonist. It relaxes the smooth muscles in the airways, opens up the airways. But it's a broad beta agonist. It doesn't just hit beta-2s. It actually is a beta agonist, not just a beta-2 agonist. So it activates beta-1s. What is a side effect after a nebulizer therapy of heart rate? You get a racing heart rate. Or your inhaler, you take a couple of puffs of the inhaler, your airways dilate and your heart rate goes up because you're stimulating this adrenergic receptor, the beta style. That's a beta agonist, agonist, not antagonist. That would be a negative, right, blocking it. An agonist pushes it forward or makes it stimulated. So a beta agonist drug is going to relax the smooth muscle in the airways, allow you to breathe easier, but the side effect is you're going to have your heart rate go up. Make sense? It's a great clinical example for you to remember how this works. Because a lot of you have these medications or know somebody that uses these medications, or you'll be treating patients that use these medications. But it's also a great way for you to remember the difference between an adrenergic receptor beta style versus the alpha sequence. Question?
Is that what a beta blocker is?
Yeah, so the beta, great question, the beta blocker, okay? A beta blocker blocks and slows down essentially the heart rate as a beta blocker because they have heart disease and you don't want their heart to work too hard. Different kind of, so pharmacologically, some students will ask, like, Keller, why do I have to know all this crap? Right? Who really cares on adrenergic receptors like alpha 1, 2 versus beta? Well, if you're treating patients and you're giving a beta blocker versus a beta agonist, does it make a difference? Yeah, you could kill the patient. Right? You give a patient that just had a heart attack a beta agonist to treat their asthma, you'll probably kill them. That would be a problem. So I hope you see that it is actually very relevant and why we study at this level of detail. So as you move on in your career, you actually have salient information that you can draw upon so that you can make good clinical decisions. Right? And I know you're not going to make these decisions in a vacuum, but you might want to be, you don't want to be that, freshman nurse on the ward asking the doctor, hey, are you sure that you're not screwing that up? I mean, you might just say, hey, I just had a question. What was the pharmacology of that beta, agonist? I know he has asthma, he's having trouble breathing, but didn't he just have a heart attack? Is that something we should maybe think through? I mean, there's ways to bring up that conversation, but perfect example right there of why this information is so valuable. Yeah. Yeah, question is, could high heart rate be a contraindication for using a nebulizer or like an albuterol? Yeah, I mean, it's going to be up to the physician, right? But if you have pre-existing conditions, and that's why they ask for medical history, it's just not one med is good for everybody, right? And you need to know, what's happening with the patient. And that's just a great example of how nebulizers seem so benign. But if you've ever had a nebulizer therapy, you've ever had like bronchitis or pneumonia, even if you don't have asthma, it's a very effective bronchodilator. But if you have an underlying heart condition, it can be very dangerous, and you'll know it really fast. So here's one of the tricks that we'll do clinically on patients that might be susceptible to rapid heart rate, like pediatric patients. You lower the beta agonist dose, you pause the nebulizer therapy in between, and you do a rinse of the mouth because you absorb a tremendous amount of the beta agonist drug through your tongue and your mucosa in your mouth. What comes into the lungs will dilate the lungs. You just don't want it going into the bloodstream in high doses and causing pediatric tachycardia, which would be high heart rate. Yeah, totally, but it's kind of fun. Oh, the question is having asthma make you more susceptible to getting bronchitis and other types? It can. Usually it's a weak point, it's a trigger point, but bronchitis is more of just like an infection in the bronchioles, and so everybody's at risk for it if you're around airborne bacteria or viruses. You probably will be more symptomatic if you're an asthma sufferer. Okay, so back to the lecture. But that little side tangent was part of my notes on the beta agonists, okay? And talking about heart rate. So that's a great example, a clinical example that you might see like in a test type of question where we're kind of comparing and contrasting beta versus alpha. And down here in the weeds on mechanism, we're looking at beta 1s versus beta 2s, right? And it makes a big difference. Okay, so we've got two types. We've got alpha and we've got beta. Alpha and adrenergic receptors, typically, norepinephrine is going to excite. And for alpha 1s, you get vasoconstriction. And for alpha 2, you get what's called smooth muscle cell contraction. And that's what you see down here. And these really are kind of very similar because vasoconstriction of the blood vessel, it's the smooth muscle layer of the blood vessel that constricts. That's why it looks a little contradictory. Like it says smooth muscle cell constriction or contraction, smooth muscle cell contraction, and these are listed differently. This is just talking about the activity in the blood vessel, which is where your alpha 1s dominate. Your alpha 2s are just found in other locations where there's smooth muscle. The alpha 1s tend to be located in the vascular system. Beta adrenergic receptors. Usually norepinephrine is going to inhibit. So if it's a beta 1, you're going to get an increase in heart rate contraction, which is sort of the exception. Beta 2, bronchodilation, is going to relax the airway. Okay, so what we'll probably talk about on the exam is that example of a beta agonist and walk you through that talk track because I think it's a really nice example that underscores the difference between beta 1s and beta 2s. Where do we find these things? Well, if you go back to our divisions of sympathetic and parasympathetic, you can kind of see how it separates out. We've got a preganglionic fiber, back to our drawing, and we have a postganglionic fiber, the drawing I had you do in the beginning of the lecture. At the preganglionic fiber, it's always cholinergic with sympathetic, and on the postganglionic, it's mostly adrenergic. Sometimes it's cholinergic. Parasympathetic, always cholinergic, always cholinergic. And this motif we'll look at here in a second when we kind of unpack the drawings that you looked at. But let's look at this question. Norepinephrine binds to beta adrenergic receptors on bronchioles, right? And you'll get into more of the bronchial thing in 202. That's respiratory phys. But it's fun to kind of foreshadow on where you're headed and talk about some of these fundamental physiology receptors. So when you get it next semester, you'll be like, oh yeah, I totally remember that. So in this question, we've got receptors on the bronchioles, beta adrenergic, binding to which type of receptors? Beta 1s or beta 2s? I guess you could go with cannot tell from the information given, but you can. Beta 2s. Well done. Beta 2s. Okay, let's go to our drawings. What do you remember? Right? You've got a long short and a short long. See if you can label the following on your parasympathetic. Right? And some of you might be asking, like, okay, I forgot, parasympathetic is which one? Long, short. Short, long is your sympathetic. That's this one. Go back to that drawing and label where you think these receptors might live. Take a stab at it. If you do it wrong, you can always redraw it. Then I want you to add neurotransmitters that make sense, kind of based upon that chart. Okay, so you're adding neurotransmitters to your drawing after you make that drawing. All right, let's take a peek at an example out of a textbook. You can draw a circle with a stick and then like a Y, and then a circle with a stick and a Y, and then a target cell. Some of you looked ahead, you know the slides were coming, so maybe you just went to it. So here is our stereotypical parasympathetic fiber. Long preganglionic neuron innervates onto a short postganglionic neuron. And we said the motif at this synapse is acetylcholine with a nicotinic receptor. And then we said acetylcholine with a muscarinic receptor on the target cell. Now, why have two different synapses? I'll ask the question that maybe some of you are thinking. Why have two different synapses? Just think basic general rules of thumb. What does that give you? More control. It gives you a level of control. It'll be a little bit more obvious when you look at the sympathetic adrenergic and sympathetic cholinergic. Remember, the motif is short, then long. We've got acetylcholine nicotinic at the first synapse, acetylcholine nicotinic at the second. But here on adrenergic, we substitute norepinephrine. And here we keep acetylcholine. So now you're getting a sympathetic adrenergic pathway, a sympathetic cholinergic pathway, and you've got different levels of target cell control based upon different neurotransmitters that you release. And this motif is exemplified in the body with many other examples. These are sort of the three variations I want you to commit to memory. Make sense? So draw them out. If it helps. If you're a flashcard person, make flashcards. If you're not a flashcard person, don't try to become one now because everybody's doing it. Like, you know at this point if it works for you or if it doesn't. Right? It was always frustrating for me in college because everyone would be doing these like different study tools, and I would think, am I supposed to be doing that? And I'd try, and it didn't help me, and it didn't work. And at this point, you should know. Yeah, so the question is, will the muscarinic receptor always be on the target cell? And in these examples I've chosen, yes. In the body, no. You'll have examples where you'll have acetylcholine or a nicotinic receptor on a target cell. In fact, when we get to muscle phys, you'll look at the target cell being the muscle, and you'll see acetylcholine binding to an acetylcholine receptor. Okay, but for this unit, to kind of focus your efforts, this is the motif I want you to be familiar with. Okay? All right, so here's another example. Fight or flight response. Which receptor on the piloerector muscle responds to the released neurotransmitter? So what is a piloerector muscle? Anybody remember? Raises the hairs on the skin. Do you remember what type of muscle it was? Visceral, also known as smooth. Thank you. Yep. I agree. It's visceral, but I was trying to use terminology that we're using in lecture here. Okay, so given this information, what do you think? Alpha adrenergic, nicotinic, beta adrenergic, or muscarinic? A, alpha adrenergic. Well done. Okay, let's talk about dual innervation. So there's a number of examples in the body where we see dually innervated tissues. Like we talked about bladder, we talked about heart in the micturition and baroreceptor reflex. We're going to look at the eye as the pupil as a dual innervation example. The viscera has both sympathetic and parasympathetic. And in some cases, these activities can be antagonistic, parasympathetic and sympathetic. In some circumstances, they can be cooperative, where one turns off and the other turns on to yield the same effect. So we saw that with the baroreceptor reflex, right? So if you want to raise heart rate, you're going to turn off parasympathetic, and then you're going to turn on sympathetic. So they're agonistic. Remember that term, like a beta agonist that we talked about? That word agonist means stimulatory. Antagonist is inhibitory. So some cases, they can be against each other. In other cases, they can be cooperative. The pupil example here is an antagonistic example. So what we see is up top, you've got the brain, central nervous system, spinal cord. You've got a spinal nerve coming off of the spinal cord to a ganglion, just a collection of cell bodies outside of the central nervous system. That ganglion, we're highlighting one route, one pathway that innervates down via sympathetic fibers onto the iris and the pupil. And here, when this sympathetic activity is stimulated with an adrenergic effect, you get a dilation of the pupil. At the same time, you've got parasympathetic activity coming out of basically the brain stem, oculomotor nerve, cranial nerve 3, innervates into a ciliary ganglion, just another collection of cell bodies outside of the central nervous system, a relay center, if you will, innervates also onto the iris and the pupil, and stimulates a cholinergic effect to get pupil constriction. So if you want to dilate your pupils, it's a sympathetic activity. Now think about this. When would you want to dilate to let more light in? When you're hunting, you're trying to see something, you're awake, you're trying to figure something out. Okay? The constriction is a parasympathetic response. So here we've got two different PNS, SNS antagonistic activities to dilate or constrict the pupil. You follow? Now, let's look at agonistic effects on saliva formation. So the parasympathetic nervous system is responsible for saliva secretion, the watery secretion that comes out of the salivary glands. And the sympathetic nervous system actually makes mucus, and that mucus helps to concentrate the enzymes in the saliva. And these enzymes in the saliva are there to help break down the food. So actually digestion, and you'll see this next semester, digestion is a term that refers to the chemical breakdown of food parts. And it actually begins in the mouth because the saliva has these enzymes that break down your food. So one organ, the salivary gland, is responding to parasympathetic innervation to make saliva and enzymes. The other one is making mucus. Okay? Now, if you get an example with methamphetamine use, you've got this situation that persists where you stimulate the sympathetic nervous system, okay, with methamphetamines, and you get this condition known as bruxism, where that's the clenching and grinding of teeth. There's typically poor oral hygiene because they're out doing other things. They're not brushing their teeth. And you have hyposalivation. Why hyposalivation? Because you're not making the watery secretion, you're making more mucus to concentrate the enzymes. And what happens in that condition is this sort of meth mouth result. Okay. All right? So an example, another clinical example, just to highlight agonistic effects of the parasympathetic and the sympathetic nervous system. So dual innervation, is it always necessary? Yes or no? No, it's not always necessary. It's just sometimes we'll take advantage of it. But I want to show you an example here in the first panel up top where we've got vasoconstriction happening of the vessel. And so now you'll start to appreciate, I think, some of these drawings because you've got the background and the history. This is a blood vessel. You'll see blood vessels next semester. This is a nerve. This nerve innervates the smooth muscle within the medial wall of the blood vessel. And what do these hash marks across that nerve indicate? It's just action potentials. Yeah. It's spatial or temporal. We saw it in the spatial or temporal slide. So this is just telling you you have electrical activity down this nerve. You're firing that nerve. That nerve is a sympathetic nerve, and it's causing vasoconstriction. Over here, you've got the same nerve. Do you see how short and quick these firings are? Compared to here where they're spaced out, there's less nerve activity. You're not constricting the muscle as much because you're sending fewer signals to contract. So now you vasodilate by just sending less tone, less of a signal to the same tissue. It's just a sympathetic nerve fiber. There's no parasympathetic, so you have just the accelerator. But you can, if you time it well, you can still slow down with just an accelerator, right? You take your foot off the gas completely, and you give yourself enough time, and eventually you'll slow down. So this is an example of single innervation, not dual innervation. And we're kind of incorporating a couple of concepts from the last unit where now you've got this nerve that's a sympathetic nerve. You've got higher temporal summation of action potentials. Here you have fewer signals being sent down the nerve, and you get a vasodilation instead of a vasoconstriction. Make sense? So you've just had lunch. You're beginning to the process of digestion. And which type of receptor in your heart wall is responding to the released neurotransmitter? So is this sympathetic or parasympathetic? After lunch. Parasympathetic. That's the food coma that you start to feel, right? Alpha adrenergic, nicotinic, beta adrenergic, muscarinic, cannot determine. Thoughts? D muscarinic? Yeah, absolutely. Well done. You know it's on the parasympathetic side. So look back at your charts. Look back at your short, long, long, short. Okay, maybe the ones that we have in lecture, not necessarily the ones that you drew, but it was a good try. I wanted you to practice. Okay, let's try to integrate some things as we wind out this lecture, and I think we're going to have time to start muscle physiology, which is good. And you'll see why it'll be good to start it early, because there's a lot of material. So we've got a slice of the brain, mid-sagittal section. We're looking at the autonomic nervous system. We've got cerebral cortex involved. We've got the hypothalamus involved. We know that the cerebral cortex involves things like the limbic system, which is kind of what's highlighted in this slide right here, is the limbic system. You can see the hippocampus. You can see the amygdala. Now, the hypothalamus, the major controller of things like hunger, thirst, temperature, emotions. Am I going to ask specific questions about what does the hypothalamus do? No, but do I want you to remember that it does some of these things so that you can answer a question based upon what the hypothalamus is responsible for? Yes. Okay? So it might be embedded in the question. That's the cumulative nature of it. You know that you've got midbrain, pons, medulla oblongata. We've talked about different cranial nerves. We've talked about pupil constriction. We went over that. We talked about salivary glands, heart rate. We talked about the viscera and the role of the vagus nerve. And we talked about spinal cord, and we talked about these. We didn't really cover defecation. We focused on micturition, right, in the video. I thought that one was a little bit better for a video, to be honest. So, answer this question. The following could occur together, effectively, except which one? Any volunteers? Someone in the very back. I kind of want to get a volunteer in the back. Which one of these things doesn't fit? Kind of synthesizing some info. Yeah? It is digestion. Why? Does it make sense? A, B, and D are all sympathetic activities. And D is parasympathetic. Right? Okay, questions. Probably the most difficult material in today's lecture is cholinergic versus adrenergic. Okay? I fully anticipate that's where your questions will be as we move on.